Good afternoon, everyone. Thank you for joining me in today's session. I'm excited to lead this conversation today, and I hope that you'll join me and bring your lived experience and professional experience as we talk about race, wealth, and health. I've titled this presentation, An Examination of Race, Wealth, and Health, Unmasking African American Adverse Health Outcomes. I do want to give you a little bit of background. I'm Dr. Staggers. I'm an assistant professor at STCC in social and behavioral sciences. I'm a medical sociologist by training. I'm also, and I consider myself to be a race scholar. And my area of interest is really examining discrimination and specifically racism on the impact of racism on African Americans. So I've spent most of my academic career in the research and writing I've done with really exploring this in terms of the impact. I've done this as going back years ago with my dissertation, really trying to understand how obesity, for example, was correlated with experiences of discrimination. And there's been actually plenty of research over, I would say, probably at least 2 decades worth of research that explores and examines this connection from impacts on breast cancer, impacts on heart disease, high blood pressure, mental health, et cetera, in different racial ethnic groups and other marginalized populations as well. So I'm very excited about this talk. And I do hope that today you're able to think about your community, think about people who you love, and really think about their social and lived experiences and how they can collectively impact health. Next slide, please. So just to get started, I do have some questions that I'd like for you to consider, just thinking about your community health, because this conversation is really a lot about where we live. And although when someone presents to a healthcare facility, oftentimes we're presented with certain numbers, whether those numbers be our weight, our blood pressure, our, et cetera. But one of the most important numbers that we'll hear about, that we know about, that can affect our health is really our zip code and where we live, and that is important. So I want you to think about where you live. Is the community where you live generally healthy? Is your community plagued by illness? And if so, what? What are people sick and what are people dying from? These are questions that are important for you to think about because it can really speak to inequity. And when I speak about community, it could very well be the neighborhood. A neighborhood is very important, with the zip code being an important indicator of health, but also communities that you may be a part of. Think about your church community. Think about a community, a religious community, if you feel very tied to a particular ethnic community as well. These are similar questions that you can think about to gauge the health overall of a community. So there are broader questions that I'd like to consider as we move forward today. And one are, why are the people in some communities healthier than others? And specifically, why are some diseases more endemic, or why do we find them to be concentrated in certain communities? And also, why do death rates differ across regions, race, ethnicity, class, and gender? So again, I did emphasize that this presentation will focus on African American health. I'm going to say now for convenience disparities, but I do want to challenge us to think about them as inequities. And I'll state it here and it will come up again. Often in public health, we really differentiate between a disparity and an inequity. A disparity is just a matter of noting the difference. And an inequity actually speaks to what is socially structured, what is actually preventable, what is avoidable. And there lies in a solution, right? In terms of, we recognize that this is an inequity and that it's social in nature. There is something that we can do about it. So in terms of life expectancy, and I want to point out here as well, life expectancy and infant mortality rates are very sensitive indicators to inequity. We can look at and compare life expectancy, rates of life expectancy, and rates of infant mortality, and we can gauge the health of a population. So if we're seeing lower life expectancies for a nation, or even within a specific population within a nation, we can recognize that there are broad social inequities that we're dealing with. In the United States, African Americans can expect to live 3.5 years less than their white counterparts. We see that these rates actually decline for Black men to less than 6.5 years. And regarding infant mortality rates, African American infants are 2 times as non-Hispanic whites to die in infancy. And we see that the rate of death due to low birth weight actually increases by more than 3 times in infants. And what's not noted here, though, too, is that we see significantly high rates of maternal mortality. So Black women giving birth, after giving birth, and then a year or 2 after giving birth, we see higher rates there for maternal mortality rates. So the leading causes of death, I also want to emphasize, we see here heart disease, cancer, unintentional injury, stroke, diabetes, chronic lower respiratory disease, kidney disease, HIV, and then septicemia. Actually, Keith, can you just go back to the previous slide, please? I just want to emphasize something. And I just want to make notice of the slide here, though, too, is that you'll notice that a number of these diseases can be chronic, so people can live with them over time. And we're going to talk more about COVID today, but what we've learned, and I think most of us are well aware, that when we see pre-existing conditions, that actually makes someone more vulnerable to COVID and then fatality from COVID, okay? So we're looking at these leading causes of disease. That actually speaks to some of the higher rates of COVID that we see among African Americans. So more about morbidity and mortality. So mortality speaks to death. Morbidity speaks to years of life lost due to a loss of ability. So in 2020, African Americans are twice as likely to die from COVID than their white counterparts. And I have some slides that we'll look at, though, too. So we could talk about rates, and then we could talk about hospitalizations of COVID, and we could talk about death. And this can be for multiple conditions. But what we're talking about here, though, too, is really death and people dying from COVID. In 2015, African American children had an asthma death rate 10 times that of non-Hispanic white children. African Americans have the highest rate of any racial and ethnic group of all cancers combined for all major cancers. And African Americans are almost twice as likely to be diagnosed with diabetes as non-Hispanic whites. So more about mortality and morbidity. And I just have to probably forewarn you, I get kind of used to speaking about morbidity and mortality rates, but the reality, we are talking about life in people. When I teach this in public health classes, and when I speak to students, when we're looking at this type of data, it is important to be thinking about people and not just numbers. And I just say this too. So it's, as I'm rolling off these numbers, please keep in mind that what we are talking about family members and loved ones. Okay. So African American adults are 40% more likely to have high blood pressure that is uncontrolled. And 43% of HIV infection rates, okay? And what's noted here is the percentage of the African American population. And this is for any of the diseases that we're talking about. When we see high rates of infection, when we see high rates of mortality, and then we recognize the percentage of the population, we can also appreciate that what's happening is we're seeing excessive mortality. So we're seeing a lot of death, we're seeing a lot of morbidity in a population that represents 13% of the population of the United States. So this particular table actually will give us a picture of really who COVID is affecting, okay? And we're all at this point affected by COVID. What it actually is speaking to is really here emphasizing the death rates. Okay, and I have a slide that comes after that. We'll look at this a little more deeper, but it does emphasize, too, that if we look at I'm going to say BIPOC people, so the Black, Indigenous, and people of color. So we see Black, African American, American Indian or Indigenous people, Hispanic, Latinos, and then also API populations. We see particularly higher rates of COVID, and we see deaths from COVID. This is actually a table emphasizing the deaths from COVID, and we see that African Americans have some of the highest death rates. This is actually a CDC slide, and actually there are 3 categories here. Keith, can you just go to the little table on the left? It says cases, hospitalizations, death, top left side. Over a little bit to the other side. Yes, exactly. There, the categories there. So we see the categories of cases. If you go down to this cases, and then hospitalizations, and then death. Thank you. And what I just want to emphasize, though, too, is we're looking at three areas here. We're looking at the number of cases, okay? And we could see across the board, and this table actually just shows BIPOC populations, just Black, Indigenous, people of color, Asian Pacific Islanders, I believe, are represented here as well. So it's showing that overall we're seeing higher cases because all of, for each group, the cases are indicated as higher. We're seeing some of the highest number of cases, however, in Hispanic, Latinos, Native American, Indigenous populations, and then of course, Black populations. And in fact, we're seeing more cases, according to this chart, in Hispanic, Latinos, and Indigenous populations than we do in Black populations. And then if we go down to hospitalizations, we see the highest rate of hospitalizations with Native American, Indigenous populations. Okay, thank you, Keith. And when we get down to death, we actually see a shift here, though, too, where we see death rates highest, and all of these are high in African American Black populations. So I'm actually going to ask you to utilize your, I guess the feature would be the hand raise feature, so you can raise your hand if you choose to respond to this question. So provided the data that I've just shared with you, the question is, why do African Americans experience poor health outcomes? Okay, so these are some of our choices. And I'll ask you to raise your hand in just a second. Do you believe it's due to genetics? Raise your hand if you think that it's due to genetics. Okay, no one's raised their hand. Health behavior. No one's raised their hand for that one either. Okay, could be. Okay, so I see one person. Okay, raise their hand for health behavior. Poverty. Okay, another one. Okay, more people. Okay, lots of people. Lots and lots of people believe poverty. Okay. Okay. Okay, how about racism? Okay. So, okay. So it seems that the people are similarly thinking poverty and racism. And I think that, you know what, that those are probably appropriate, right? But they can also kind of go hand in hand. And, you know, and if I'm being honest with you, if I were to go back easily 5 years ago, it would be unusual for a majority of the population to think that racism was tied to, and I'm saying the majority of the population, that racism was tied to health outcomes, although in public health and medical sociology, this has been studied for at least 2 decades, I should say. But to be honest with you, even public health departments had not truly gotten on board in terms of the connection between racism and health. I should give a shout out to Boston, because Boston actually has been exploring and studying the connection. And actually they made it a big part of the Boston Health Commission to include racism as an indicator of public health. And this is going back probably 10 years. And at that time, Connecticut was fortunate to have a commissioner for public health, and I had an opportunity to do health policy work where we did have to talk about the other R word. Oftentimes we're looking at race-based data. It's easy for us to say, okay, well, race is in question and race is the answer, but it could be more than that. So let's talk a little bit more about race. And since folks had mentioned that, you know, poverty and race, but let's talk about race, because oftentimes, and I think that we still see this, and we saw this, I think, early with COVID data. You know, people presented, okay, when the race-based data came out, and some people kind of, why do we need the race-based data? We're all pretty much affected by this. Now, we look at the race-based data because it can tell us where problems lie, and it could tell us, you know, where the vulnerability is for different populations and where resources need to go and to be directed differently. That's why we collect data. We can collect data by gender, we collect data by age, et cetera. So it is important to have this information so that we know how to really direct advocacy and dollars where people need it. So let's talk more about race, and I want to get through this part so that we can talk about the connection to health. And health is one of those interesting pieces, though, too, because we do know of it, you know, the fact that there are specific diseases that we see showing up, you know, whether it be, you know, sickle cell or Tay-Sachs that we see showing up in populations specific, what it seems to be two racial groups. So students can get a little confused in terms of, again, if we say that race is not genetic, and it's not biological, why do we see, certain diseases actually showing up more so in population? So let's talk about race and the fallacy and the idea behind race. So first of all, and I did start with the fact that I am a sociologist. We want to recognize that race is a social construction, right? So it doesn't have biological value. That the meaning behind race is actually created out of historical use, social and political processes, okay? So it's really a matter of social definition and tradition. So what we're seeing is people being assigned to different groups. Okay, and then assignment actually having social and political meaning based on how people are placed into groups. And we still see this today. So I think, and I'm going to speak about the institution of slavery, for example, that actually in this country was paramount in really defining and placing people into racial groups. And there, one of the we can see, like, we take the concept of one drop rule. If someone had a drop of Black blood, they were therefore determined to be Black. We still see that actually today. If we look at this image in front of us with people, we may not be able to really place any one of them easily into one particular group, right? We could try to place them into one group, and that would be our attempt to socially assign people to a provided group. But we could be wrong, right? So how we see them may not be how people actually assign or associate or how they self-identify racially, okay? But we could very well look at them, and for our convenience, we could say, well, this person is white, or this person is Latina, or this person is indigenous, or this person is African-American or Black, okay? But we may not be consistent, or at least our assessment may not be consistent with how someone identifies. But I do want to just share something else with you, though, too. It was actually a study. The study is probably dated at least 15 years old. And there was a study that actually did this. And in the study, they actually asked people, how do people typically categorize you? And then they asked people, how do you categorize yourself? So regardless of how people socially or racially identified themselves, they found time and time again that people who were generally far and wide assigned to the category of white reported better health outcomes than people, and this is again, regardless of how people actually self-identified racially. So someone could have been indigenous, but people often view them as white, or someone could have been African-American. People often thought they were white. Their health reporting oftentimes was higher than someone who was, say, indigenous, and people assumed that they were indigenous, or if they were Latina and someone assumed that they were Black, okay? So there is something about how we see race and how that actually ties to the experiences that people have. So again, emphasizing that race is social, it's not biological. So one of the pieces here, though, too, so of course there is a danger in terms of looking at race as biological. And that danger is that it actually really feeds a narrative around inherent deficiency in groups of people. But what we know to be the case is that we actually see more variation within group as opposed to people who may be from different groups, but who live within closer proximity to one another. So there is actually more similarity that people share genetically across groups, but it has more to do with people living within closer proximity to one another. So I want to speak about the physical piece about race as a construction. So whether we can, of course, there are certain things that we look at, right? So skin color, hair texture, eye color, other physical features, body build, nose structure, things of that nature. And what we often do, though, too, is we actually assume that they all it's like a package deal, right? So we see this in one person that defines, but we recognize, and I have a kind of a faded view of the same picture, is that we can see a variety of different features showing up across different people. So we actually refer to this, the language here is non-concordant. And that means that actually we can see a range of these different features showing up across different people or different populations, which makes it, kind of difficult to say that someone belongs here or there. And again, this is really, around the idea that race is social. Okay, so it doesn't necessarily have meaning in that regard. Okay, that it's social, it's not biological. Okay, but it's social and political in nature. This is a map of skin color distribution. And I wanted to just throw this map in here, though, too, just so that we have some context in terms of where this comes from, right? So, thinking about going back 50, 70, 1,000 years, the map, and look, this map actually speaks to, again, and it shows that people who are living closer to the equator actually will see darker skin, right? People who are living further away from the equator will see lighter skin. And the idea here is that it's actually functional. And it's functional because we're talking about a physical adaptation to the climate. And that darker skin tone is actually protective if someone's living closer to the equator, whereas having lighter skin is equally protective if someone's living further away from the equator. It helps with vitamin D absorption, whereas melanin is protective, if someone is closer to the equator and closer to the sun. Similarly with, hair texture, curly hair can be, useful in terms of, sweat absorption. So we're talking more about how these physical features are effective and efficient for where people live and really the climatic environmental needs. So again, the connection between race and racism, it's important for us to, again, if we talked about race as being social, not biological, not genetic, that race acts on health, all right? So what we're seeing is race acting on health through the experiences that people actually have and life opportunities. And I made a reference to a study where people were actually socially assigned to, or there was a measurement of how people are socially assigned racially, as opposed to how people identify. And that study actually suggested that racism is more important than race. So how people are actually treated based on their race seems to be more, in that study, demonstrated to be more of a predictor of their health outcome. So I want to just define race so that we have a similar language that we're using. And we want to recognize, racism, I should say. We want to recognize racism as a system, and it's a system of structuring opportunity. And I would say at the same time as it structures opportunities, and consider power being an opportunity, it also is structuring disadvantage, right? So it's not just that people have power, right, or people are privileged, it's that people are also disadvantaged, as a result of that power. So the race-associated differences that we're seeing in health are linked to and can be due to racism. So I want to acknowledge that there are 3 levels of racism. At the same time, I'm just saying, I do see some comments possibly in the Q&A and chat box. I'm going to get through a part of this, and then we're going to have a little time for Q&A. So I will definitely make sure that I address the question, okay? So there are 3 levels of racism that I want to be sure to address. And it's important that we note these different levels of racism because oftentimes people, and I love the fact that so many people are engaged in conversation today. The institutions are really pushing towards anti-racism and engaging people at different levels in conversation around race and racism. And part of that is that we need to do more work around the history of racism, right? And also how institutions have been engaged in really being complicit with institutions and structures that have disadvantaged people. I mean, that needs to be part of the conversation as well. But I do want to make sure that we're clear about these different levels because it's more than just about one person not liking someone else, right, based on who they are. So first, institutionalized racism. We're looking at systems, we're looking at institutions, whether it be a university or a hospital, looking at a government, for example. And accordingly, we could note that there are differences in terms of opportunities that are available to people, and that these differences in opportunities can very well affect health, right? So differences in terms of, goods and services. The thing here about institutionalized racism is it becomes normative. It becomes accepted. Okay, I mean, if we're watching and kind of binging on TV, okay, we get a healthy dose of institutionalized racism when we just kind of watch something and we don't question, what's being said. Okay, because different things can become normalized. It's also legalized and it's structured. So personally mediated racism is often what people talk about in terms of someone, not being fair-minded, and more than that, someone holding on to personal prejudice and discrimination, often negating where that comes from, right? And it actually comes from a person actually being part of a system, an institution, and then family structures as well. That support that. But oftentimes we have this idea about what it is, a manager deciding not to hire someone because they have an ethnic sounding name. All right. So here often it's a matter of someone feeling like they don't like someone, again, treating someone differently because of how they appear physically or who they may be. So personally mediated racism, how it manifests in terms of suspicion. Just want to point that out. Devaluation, scapegoating. Lack of respect. And then there's internalized racism. And internalized racism happens when there's someone who is a member of a marginalized, disenfranchised group, and they also hold on to beliefs about people who look like them. Okay, so I would say that all of these different levels support one another. All right, and at the highest level, institutionalized racism makes it so that they do. So how do sociologists, how do public health practitioners measure racism with regards to health? And I'm going to share with you a couple of scales that are used. This is an everyday racism questionnaire, and I'm going to ask you to implement or use your hand raising icon over there as I raise these questions, and think about yourself. Okay, think about your community, think about people who you know. But for this question, that is actually asking you for everyday racism. In your day-to-day life, how often do the following things happen to you? How often are you treated with less courtesy than other people? And I should say this though too. I see a lot of hands though too. And I'm sorry, this is how it's worded here. How often are you treated with less courtesy than other people based on your race? So based on your race, how often are you treated with less respect than other people? Based on your race, how often do you receive poor service than other people at restaurants or stores? Based on your race, how often do people act as if they think you are not smart? Well, thank you for continuing to participate. Based on your race, how often do people act as if they think you're not honest? Based on your race, how often do people act as if they're better than you are? Based on your race, how often are you called names or insulted? And based on your race, how often are you threatened or harassed? And I want you to keep that in mind. We're going to come back to this during the discussion portion of the session. And this is another tool that we use. It's the everyday discrimination scale. I've used these scales in my own work. I use them specifically for a data set. It's actually an NIH data set that I was interested in, and I still, use from time to time, called the Cardia study. And that data set actually looks at discrimination specifically. There's a black-white sample, and it's focused on heart disease over time. So it's a longitudinal study with several waves and explores the impact of discrimination in heart disease. And just to note here, though, too, this is an everyday discrimination scale. And when I did my dissertation and people who use scales like this, you can be looking at this scale from the perspective of racial discrimination, gender-based discrimination, discrimination based on sexual identity, discrimination based on class. And it's really interesting when these things intersect. I'm not going to speak a lot about intersectionality today, but the reality is that people do experience different levels of discrimination and even a matrix of it when we look at all those multiple identities. And I did want to just acknowledge that. So with regard to the everyday discrimination scale, again, I want to for you to think about based on race. At any time in your life, have you ever been treated unfairly, or unfairly fired, I should say, excuse me, based on your race? At any time in your life, have you ever been unfairly fired? Okay. Based on your race, for unfair reasons, have you ever not been hired for a job? Okay. Okay. So based on your race, have you ever been unfairly denied a promotion? Okay. Based on your race, have you ever been unfairly stopped, searched, questioned, physically threatened, or abused by the police? Okay. Based on your race, have you ever been unfairly discouraged by a teacher or an advisor from continuing your education? Based on your race, have you ever been unfairly prevented from moving into a neighborhood because a landlord or a realtor refused to sell or rent you a house or an apartment? Okay. Based on your race, have you ever moved into a neighborhood where neighbors made life difficult for you or your family? And I'm just going to be honest here, kind of just a vulnerable moment myself, too. As I'm saying this, I'm feeling the weight of this. And one of the, I'm having one of those moments where it's interesting to be around people when I give this talk, because there is kind of, I think, a shared, understanding of the weight and the toll of discrimination and in how people are dehumanized collectively. And one thing I want to point out, though, too, is, and I think that people lose sight of this, is that multiple forms of discrimination happen to people. And again, here we're talking about African Americans, and I'm talking about racial discrimination. So you can take multiple forms of this racial discrimination happening to people, not just one day a month, okay, not just one time a day. I'm talking about several times in several forms over the course of the day, over the course of the week, over the course of the month, over the course of a year, over the course of a lifetime, okay? So asking these questions, and hopefully, and again, I shared this data, but I want you to think about people, okay? There is a weight, there is a toll, there is a cost to this, because we're talking about real people in real lives. And it's not just one thing. I know so many of us were moved by people literally witnessing the murder of George Floyd, but there are people who worry about that every day. There are people who, every time they get in the car, they send their son out, to run to the grocery store. These are real concerns. And that's one level of it. But there's also, people experience different, tough situations at work, right? People experience tough situations in the schools where they're sending their children. People experience tough situations in the neighborhoods where they live, where they spend their money, right? There are policies that are discriminatory. So we're seeing this, again, over every day, right? That's why it's called everyday discrimination. And we're seeing this over the life course. So I just want to point out the social determinants of health. And this gives us context, though, too. And if you go over, well, actually, let me just speak briefly about the social determinants of health. For those people who are not well-versed in social determinants of health, these are really social factors. And what I didn't say that what medical sociologists do, medical sociologists, there are two, we kind of operate in two veins. On one hand, there are those folks who go right into healthcare. They study healthcare systems, right? And I'm kind of a combination, but I do a lot more, I think, of the social aspects of it. The social aspects and the social determinants really look at those social factors that happen in our broader social environment that impact health outcomes. So we look at economic stability and how that impacts health, neighborhood and physical environment. So we consider housing, transportation, access to all of these factors, education, food, community and social context, healthcare system, and all these social factors. And you can appreciate all of the indicators underneath each category, right? All of these areas, and this is just a snapshot of what can be studied. Under community and social context, you'll find discrimination, just to place discrimination and specifically racism in the context of our talk, in terms of appreciating this as a social determinant that shapes health outcomes. Okay, so this slide actually shows the pathways from racism to health outcomes, all right? And I love pathway charts because on one hand, it shows what's happening at the policy level, and then it shows how we get from the policy level and institutionalized practices to how people actually experience health. So what I will emphasize, because there's a lot going on here, in the lower left-hand corner, you'll see the category of racism. Okay, in that box, thank you, Keith. And then racism actually comes before race. And what this model is actually trying to suggest is that it's not so much race, it's racism. And because of racism, again, we can then say, okay, well, you know, we look at race, but we don't look at how people experience how they're labeled or the category that they're placed in because of racial discrimination. Now, what happens though too, we go to that proximal pathways, that middle category there, that middle column, and I think that this is probably perhaps the most interesting column here because something happens between the proximal pathways and the response. So in the proximal pathways, we recognize that we're seeing a lot of stress, discrimination, we're seeing the threat of stress. And, you know, so I asked you those questions before about how often you experience discrimination based on all of these things. Not only do people experience discrimination, not only do people actually perceive the discrimination, people also anticipate the possibility of that discrimination. And if you think about all of this hypervigilance about the experience, but even the anticipation, we're talking about a lot of stress, okay? So the other piece here, though, in terms of other proximal pathways, socioeconomic status, okay, so class status, education, employment, wealth opportunities. And I appreciate here they also have incarceration as the opposite side of that, okay, in terms of opportunities that actually are limited for people to actually secure wealth or to engage in wealth building. And of course, we know that changes the status of the community. And then from the proximal pathways, we go to responses. So when people are exposed to stress, what happens to them? What happens to their bodies? Okay, so there are, and I think this is a significant point. This is a significant point for any of us. When we experience stress, what do? Right? And I'm going to break this down so it's very simple, okay, for any of us. When we experience stress, do you sit in the corner and do you breathe? Okay, do you relax, you know? Or do you decide, you know, if there was no COVID, would this be a night to go to the bar with your friends, right? Do you count to 10, you know, play some soothing music, or if people smoke, is this a time for you to go and smoke a cigarette because of the stress? All right. So we have to talk about the response part. Now, I actually removed a slide that I was going to show because I think it got there was a little too much, but it's interesting, is that some of those coping mechanisms, even the coping mechanisms that we view as bad coping mechanisms, you know, in terms of someone eating the wrong thing, someone deciding to binge drink or smoke a cigarette, the thing here is that immediately they're protective. Immediately there is some protective nature to what people alleviating the stress from what they've been exposed to. But what happens is that long term, there is an impact. Long term, we're going to see biological consequences. And then we move to the last category of health. And then if people are engaged in these processes that are not very healthy, okay, we're going to see changes. We can see changes in terms of mental health. We could see changes in terms of physical health. We can see the decline. And when we look at African American health, of course, it's not just a snapshot, right? But we have to be thinking in terms of the life course. People experiencing, engaging in practices of their life course. I'm getting close to time, so I want to go a little bit faster here because I do want to hear from you. So some of the pieces here that I do want to point out, considering institutional levels of discrimination, considering even, behaviors. Okay, I want to put that in context because, the question always comes up around a matter of choice, right? I remember just about a week ago, I shared something that I thought was really cool on social media, and I loved it. And this was a post about choices. And it's like, being overweight is hard. Being fit is hard. Choose your hard, right? Being married is hard. Getting divorced is hard. Choose your hard. And I was like, this is great. This is awesome. And a friend of mine, she shared it on her social media post. And then someone commented on my friend's post. And I had to check myself. I'm like, I wasn't wearing my critical sociologist hat that day because the person commented, yes, this is lovely. But what happens when you don't have a choice? And I think that's significant because I think that as much as we'd like to think that we always have choices, some of our choices are some of the things that we're choosing between are not, we don't have very much. People have very different choices. And that's what we're talking about when we begin to talk about privilege, okay, and then disadvantage. But one of the pieces I want to mention is neighborhood. I started with, just the idea of even zip code being an important number. But it's just important to note here, though, too, that, neighborhood is a huge factor, and it's noted as a social determinant. And there are so many levels to neighborhood. It could be the housing stock. It could be what people actually have to their avail to improve health outcomes. Medical offices that people may or may not have access to, right? So I want to talk more about medical care. Medical care is important, though, too, and I don't want to de-emphasize the important when I mention the fact that zip code is the most important indicator of health. It is in terms of where you live. So a doctor can tell a parent, well, you just have to make sure that your child who's overweight goes outside and exercises, 5 days a week, and that you are eating the right food, that you have, enough fresh fruits and vegetables that you're feeding him. Right? But this may not be feasible for the mother if she doesn't have access to transportation, if there's not a grocery store that's nearby, if she doesn't have the financial means to go grocery shopping as often to have fresh foods for her child. But we have to also talk about the challenges with medical care. Some of the challenges I just want to point out with medical care here are, one, access. We see completely different forms of access to medical care. On one hand, we see, specialty care is challenging. Specialty care is challenging because there are not enough practitioners in certain communities that offer and accept various forms of insurance for specialty care. But the other piece, though, too, and I want to mention here that there are a number of communities of color that facilities are closed and that people don't always receive appropriate care. And when I speak about appropriate care, I'm talking about culturally competent care. So that could be care provided to you in the language that you speak, which is actually a civil rights violation if it does not happen. Everyone is entitled to care in the language that they speak. Children should not have to interpret health care for their parents because health care, language in medical care is very different than regular conversation, okay? Also, we have to appreciate the fact that providers have their own unconscious biases. There have been numerous studies that have examined how practitioners feel about patients. And time again, it's been noted that practitioners have different perspectives and different views and actually prefer white patients to Black patients. It was a question that was raised in a study, and it was actually asking practitioners for the white patients, and what they actually found was for the white patients, practitioners often saw them as family members, often saw them as neighbors. And that same feeling and sentiment was not applied to Black patients, regardless of class. And I want to emphasize that because I think that it's easy for folks to think, well, it's a class issue. And if we address the class issue, it will not happen. Parents who are from middle to income class still worry, if they're parents of color, about their Black children and their Black sons going out, okay, and fear about police brutality, absolutely. Women who are often higher educated and Black mothers, okay, often have higher rates, experience higher rates of maternal mortality, okay, than women from lower socioeconomic classes. And the same for infant mortality. We see very high rates in Black women who have higher levels of education. The other piece here, though, too, is in terms of access to medications and pharmaceuticals. We see that there's less access to pharmaceuticals, and really in terms of opioid-specific medications to reduce pain in communities with higher Black populations, all right? I want to also emphasize employment inequities. And I want to state this, though, too, because I've been back and forth with COVID on this. And you might recall, though, too, that, it was noted that, people who are doing a lot of, frontline healthcare workers, of course, but then even frontline workers in general. So people who are bus drivers, people who are in those front-facing social service or those people who are at the front desk people, okay, people who are greeting folks. Oftentimes people of color are disproportionately in those positions. And we saw very early on that we saw a pattern of people who are in those same levels of occupation at risk for COVID. And this is actually just another, in a current contemporary perspective on how this happens, but there is a strong association between work and where people find themselves occupationally in vulnerability to disease. And the last piece here that I want to mention before some closing remarks is environmental racism. So I mentioned neighborhood as well, but the other piece that I want to point out is that communities of color are oftentimes living within closer proximity to toxic hazards and toxic sites. So many of the conditions that we see, such as asthma, certain forms of cancer, and then there's even been studies that speak to the obesogenic environment, right? So living within closer proximity to these sites puts people at more risk. So if we think about people not having access to grocery stores, people living within closer proximity to toxic waste, toxic sites, okay, we can see how these health conditions can also be chronic and persistent. Okay, I do want to point out this slide. And I actually like to think of this slide as where the hope is. And I say this here because it's very clear here that we start with the social political context, but the social political context actually speaks to policies, right? So policies are one way that we can address this inequity. I did make a point to emphasize that when we're talking about health inequities, and we use that language specifically, not just determinants, or not just, I should say, disparity. We use that language specifically because the health outcomes that we're seeing are not natural in nature because they're socially defined, right? We're talking about policies that can help to change how people have access to food, how people have access to employment, how people have access to transportation, how people are treated, right? And then we have the other part about this in terms of accountability for institutions to make sure that they're following through on these policies. So although I know that the data that I provided to you is rather gloomy, but I do want for us to be thinking about, possibilities for advocacy, possibilities, for policies that need to be implemented, and becoming involved in understanding, I think, though, to why it is. I know that organizations are involved in DEI work because there's an impact. And I think about health as actually being one of the most sensitive indicators of that social inequity. Keith, I'm actually going to stop here. I have some closing slides, but I think that it would be more important to have some conversation. I know that some people probably have to have a hard stop at 3. So we can go ahead and kind of start some conversation. Okay, so I only have one comment that was made here, and that comment, and thank you, Kathleen, who just mentioned sickle cell as a response to malaria, which is right. And then even malaria is prominent, the population with high incidence of sickle cell, right? So of course, we're seeing the similarities between malaria and sickle cell, right? And again, that's regional. Okay, so Kimberly Broderick has a question. What are we as African Americans to do directly when confronted with racism in healthcare? I've had many experiences with racism in healthcare, but at the time I was too sick to address this issue. This is a big question, Kimberly. One of the things that COVID actually presents an interesting concern. One of the concerns for me was that I think generally in healthcare, it's good to have an advocate, right? And especially if someone is quite sick, to have someone present with you. With COVID, of course, we're seeing that even if you go to your primary care practitioner for a flu shot, you're not able to bring anyone in, even with your children if they're of legal age, right? But certainly if you have an advocate, and I think also making sure that you're well educated in any health concern that you're addressing. And then asking the questions. I oftentimes, and I've just accepted the fact that I often take the hit, in terms of, sometimes your people are not going to always like you. But I think it is important, especially with healthcare, to understanding what you're fighting against. And you want to make sure that you're getting equitable care. So you have every right to push for what it is that you need. You have every right to push for the testing that you know that you're qualified for. Some of the things that we do know that African Americans are less likely to get the tests and life-saving tests and life-saving procedures that they need. So I would say that it's important to be diligent to make sure that you're well informed. And if the provider that you're working with is not working with you and is not working in your best interest, certainly change providers and keep researching providers that you may need. I think that Deb, you did send me a question via email, and the question actually I think had to do with more along the lines of why is this important and why would people actually care about the impact of health inequities on people of color? I'm going to answer that in a very broad way. Some years ago, I would say probably about 10 years ago at this point, I was working for the Connecticut Commission on Health Equity, and I was actually the first executive director for that commission. And we were intentional about that work. We were actually positioned in the Office of Healthcare Advocate for the state of Connecticut. The Office of Healthcare Advocate's work for the state of Connecticut spent a lot of time really celebrating finding money to reinvest in the state. And we were there for quote unquote administrative purposes only. But part of that work and the intentionality of placing us there was that there was recognition that addressing health inequities was a cost savings. The United States spends the most money of any nation in the world on healthcare. If you were to compare our rates of mortality rates, life expectancy rates, and infant mortality rates, our rates are higher than certain developing nations. People are oftentimes, concerned and I think get overly concerned about having universal health care when people need access to health care. What happens is that we end up spending more money as a nation for care that can be, for conditions that are preventable, okay, for conditions that are avoidable, okay? So we would spend less money addressing these health inequities, addressing these social inequities that lead to adverse health. So there's a cost saving. So even if people are not so moved by life lost, some people may be moved by dollars. So just collectively, as a country, we're struggling because we're not addressing these health inequities. So people having access to care, that's a big part of it. But also we need to address the social conditions that folks are engaged in, that the people are experiencing. See here, I think Rufa Perry, and I don't know if I'm saying your name correctly. So you're a family doctor, and now you focus completely on teaching medical students, in addition to understanding how racism causes disease and how racism is embedded in our calculators and algorithms. What can doctors do to address racism with individual patients, other than asking how it affects them and documenting it? Okay, that's a pretty big question. I really do like that question. And I'm thinking about that for different ways because I'm just thinking about it being somewhat awkward for a patient to be asked that question if they don't have a good rapport with a practitioner. And I think that there is a before this, Dr. Perry, and the before is making sure that you have a good relationship with your patient. And you want to build the trust with your patients. If your patient actually has trust in you as a provider, they're more likely to share with you, I'm getting treated this way on the job. I'm stressed out because, the community that I live in is not friendly, right? I'm stressed out because when I go into my child's school building, I'm treated differently or my child's treated differently. People are likely not to share that with you unless trust is built. So I think that as a practitioner first, it's so important to actually make sure that you really understand your patients and that you're delivering culturally competent care, that patients are not feeling slighted by the questions that they're asking you in response to their questions, in terms of you not being accepted of who they are fully as people, in terms of cultural practices that they engage in. So people, and I want to emphasize this because when we talk about racism, oftentimes people don't talk about the pain. So as we're talking about, several institutions, being anti-racist, what happens is that, people can say, well, okay, well, I'm a privileged person or I'm a privileged white person, but oftentimes people of color are not saying, I've actually been, a disenfranchised person of color. And what that disenfranchised looks like is actually my pain, right? That I've been pushed out of places and I've been hurt in a lot of ways. So there is pain in that. So I think that before people can easily, bear to you, what their truth is, I think there has to be a certain rapport and trust building. And that trust is historic for people of color. And there's, again, a ton of research on that, though, too, in terms of having this trust towards medical practices and medical institutions. So I think before just saying, well, how do you experience racism in your life? That's insensitive. So you want to make sure that relationship is built prior to that. And then I think that you have an opportunity to begin for patients to share that with you. And I also want to add, a word of caution about this, because we don't want to somehow make conversation around racism the new sexy, because, again, when we do that, we're undermining the hurt and the pain that people feel, and that people experience as a result of this. Dr. Smith, so knowing that we're dealing with stresses of systemic racism, what can we do as African Americans to positively impact? I love that question. My screen is jumping around a bit, though, too, to positively impact our health. So the question here is, again, knowing that people are dealing with systemic racism, how do we as African Americans going to positively impact our health? This question is something that we have to constantly ask ourselves. I think the first thing, and this is the first thing that we have to do, and I'm going to keep referencing studies, but you guys will be here, for days if I think about all of the studies. Again, this is really what really gets me going as a researcher, as a sociologist. So there are studies in African Americans that, on one hand, that admit the experiences of racism and those who don't, right? So those who don't admit experiences of racism actually experience more heart disease, more hypertension than those who say, that hurt. And that was racism. So for some people, they don't even acknowledge it. I think that the first part is to acknowledge that it happened. The other part, and we don't talk about, is that it hurts, all right? And I think that the tough part, I'm going to say this is going to sound very idealistic, we're going to have some conversations about this, is finding spaces that are safe for you to engage in conversation around the pain that you experienced. And I think also being very intentional. This is the part that I speak about privilege, though, too. So even though I recognize the conversation about racism allows us to move away from poverty, but we still have to consider poverty. But the part, though, too, is that, if people have the ability to engage in practices that help you to somehow kind of cope in a way that's healthy with the stress from racism, if you're able to, like any other form of stress, to go get a massage, to get away for a little bit, to spend time and in spaces with people who you feel are supporting of you. That is preferred, and that is something that people should seek. And I think also being intentional about creating spaces so that you are not succumb to that. I mean, there are going to be certain spaces where where you go in, you're going to be confronted or viewed in a particular way, and you have to put on your protective gear. And then there are those other spaces that you go to that you're saying, okay, gosh, this is a place where I can kind of take off the mask, literally, right? Take off the armor and I can be safe. And I think spending more time in those spaces helps to protect you and being intentional about what that space looks like. So Gary, what are some ways that we can prevent the amount of COVID-19 cases from increasing besides putting on our masks and washing our hands? So Gary, I'm going to answer that question very carefully in this environment, okay? So although I have a degree in public health, my degree is in community health. I will say that while I'm a social epidemiologist, I am not a clinical epidemiologist, a disease epidemiologist, but some of the things that we can do, that we know to do, of course, are social distancing, wearing our masks. And the other piece, though, too, and a lot of states are going back to this as well, is in terms of staying home when we can. I mean, that's a big part of it, though, too, in terms of, and I know it's difficult. I have a 19-year-old son who I think he takes breaks over the course of the day about asking me how he can go visit his girlfriend at UConn. And it's a matter of repeating daily what the process is and why we're doing this, okay, in terms of being safe. Of course, there are talks about a vaccine. So we don't know much, about that and when that is going to be made available to us. We're getting more news, daily about that. But researchers are, of course, recommending that if it's out and if their studies are looking good and that it's safe, that people should get the vaccine. So, at this point, I think that we have, and I know it seems simple, but these are measures that people have taken before, in terms of quarantining and things of that nature. And I think the other part, some of what gets missed is that people don't truly understand when we're talking about social distancing, that actually means kind of staying close to people who you live with. I struggle with that with my own family. So it doesn't mean that people from outside can come into your house, right? It actually means you kind of being with people who you live with. So it's difficult if you have folks who are in a different state who really want to come see you now. But unfortunately, unless you're closely marking what everyone is doing, and I'm kind of that person, I would kind of police everyone first and kind of want to do background checks and, all of these things first, it makes it rather difficult. So, which is why we have the general process of the, more of the quarantining and, kind of if people have to go to work, going to work and coming home, if you have to go to a doctor's store and go grocery shopping, but it looks like states are slowly kind of closing down a little bit too in terms of some of the opportunities for social engagement. So what advice would someone who is entering the healthcare field and experiencing racism and lack of representation? That is very common, Hajar. Medical students feel this, graduate students feel this, students who are sick in different health professions feel this. I actually think that a couple of things. I actually want to encourage you because I want to watch my time. I would say that the fact that you're experiencing this as a health professional, as an aspiring health professional, speaks to your need to be in that work. The fact that you're experiencing this and then you're recognizing that people who may be training you are treating you this way. Imagine how they treat patients who are ill. So you clearly need to be in the work and staying diligent, with the work that you're actually doing. And the tough part here is oftentimes, and this is across the board, from students who are at the associate level to students who are in medical school, there is the fear of retaliation if you say anything. But I would actually take the same course, and not to say that it's always going to go your way, but if you feel like this is happening, particularly forms of discrimination, I would begin to speak to someone who you can trust. And then maybe there is a plan in terms of you speaking to an administrator who is, again, after you speak to someone who you trust, okay, who can better guide you in terms of how you can address these concerns administratively so that you can be successful in your academic career. Gary's asking a question. What do you think is the reason why some people refuse to put on their masks out in public despite the consequences? I would say, Gary, that we have an issue with social messaging, and it's become politicized. And we recognize that mask wearing has become politicized, which I think, this is not very academic, but I think it's just dumb, right? It's just dumb. But at the same time, and without judgment, because saying it was dumb was very judgy on my part. But the part here is that, and this is, understandably, people have gotten really confusing mixed messages about this. This is kind of a gripe for me. If I, just kind of go out in my community, and I often wear a mask if I'm kind of even walking around from time to time, unless I'm in my yard or something, is that people don't understand that the way public health works, it's different than our medical model, right? Our medical model is very individualistic. We think about, if I exercise, if I eat the right foods, I'm going to be healthy. I think much of public health actually goes unseen, and we don't think about how these social systems are always operating for the protection of the general public. I know healthcare students, you guys can't even go into a hospital without having immunizations. For many of you, you weren't able to get through, many of us, I should say, we weren't able to get through high school, even college, without having immunizations because we're going to be around other people. Without a sanitation movement, right, which basically just cleaned the streets, we'd all still be dealing with certain forms of infectious disease. So public health systems have always been there. They've always been in place and operating. It's just been a matter of us not seeing them. I think in real time, in a day and age where we think about health being an individualistic thing, we're asked to think about other people in a way for their protection that people are not used to. So wearing a mask is a simple thing that all of us can do to show our commitment to caring about and loving other people. Yeah, I actually have, I included this slide. I just wanted to, this is actually, I had several closing slides. Can you click it one more time, but I think the image will pop up with an additional advancement. Good. I did include this slide though too. This is actually a slide that I used in a presentation in Springfield, probably going back maybe even 3 years ago. It was a great conference in Springfield, a civil rights and social justice, usually a civil rights and housing conference that's based in Springfield. And I believe that year I was actually speaking about civil rights, housing, and health. And this slide just seems so appropriate to bring to a presentation like this in this moment where people are much more aware of racism, and there's also more of a commitment in terms of being anti-racist. And just as well, we're in the midst of this pandemic with a disproportionate burden on people of color. So I've stated in this talk that health is the most sensitive indicator of social injustice. And I want to just even tie in, in terms of, again, our political activism being so important in terms of how these different factors are related. So civil rights and housing, education. And the other part there too is noting the pain and the toll that all of this takes on our body. And I here just have some, kind of recommendations here in terms of what this would actually look like. On one hand, appreciating the larger context in which health exists. I think that when we think about health, it's always in context. It's always in context to, inequity. It's always in context to access. It's always in context to barriers. So a big part of this is trying to remove those barriers so that people have opportunities and access to good health. Many of your questions have considered this, but we do want to, and we need compassionate healthcare. Right. And I would say, even outside of healthcare, we need compassionate professionals, right? We need compassionate professionals, whether we're teaching in higher education, to be much more mindful of who we are and how we're engaging with students so that we're always trying to be culturally competent, understanding who we are as professionals and how we're engaging with other people. And certainly the collaboration between different levels of systems in a society. So this work is just not on, and that's why I love public health, but too, it's just not on healthcare. It's actually on all of us. So we have to consider the connection, and COVID really speaks that. It emphasizes all of that in terms of how transportation is connected to education and how education is connected to urban planning. And then we see the connection to health outcomes. And it requires policymakers to work together. And of course, social advocacy and health advocacy. So if anyone needs to contact me, this is my email information, rkstaggers@stick.edu. And again, guys, I just want to thank you so much for joining me and for really staying longer than you could have. So thank you once again. Please feel free to contact me if there are any follow-up questions that you have.